First of all, we need to acknowledge that there is such a thing as disparities in healthcare in the United States and in New York City and in the Bronx. Don't let anybody fool you that we live in good old America and everybody have equal access to everything. That's a lie. Their foot stinking. They don't love Jesus. You don't have equal access yet to anything. You got to begin with the truth, and the truth is that we live in a racist society. Racism is alive and well in America. It's alive in education. It's alive in housing. It's alive in health care. There are no ifs, ands, and buts about it. It's just as clear as day. You don't have to be a scholar in order to recognize that fact. Just remember the fact. Just bear this in mind, that I, as a black man, according to statistics, will live 7 years or die 7 years before my white counterpart dies. Because of the problems associated with making health care available to people of color.
One of the things, it seems to me, you learn as a black professional is that as long as you are in your professional clothing or you're in a particular place, you may be treated in a particular way. However, when you go to the emergency room or when you're in contact with certain kinds of elements of our society and you're regarded just as a person of color, the treatment is very different. So what happened at this hospital was that once I got there and took off my professional clothing and I was like everybody else, I stayed there for hours. It's one of the best hospitals here in the Bronx. I was in the emergency room for 24 hours. Didn't have anything to eat while I was there. My bag was stolen. Nobody knew why. Nobody understood what happened, even after I complained. And I also noted the way the people that were there with me were treated. There was an older woman, and I would have noticed her just because of my work, but also because she was crying, and she was Hispanic, and there was no person who could translate for her. So for hours, nobody knew what was wrong with her, what her problems were. And when I asked, you know, what's going on, can we do anything? They explained to me they didn't have a translator. I asked, well, this is a community where there are lots of Latino people. What do you mean you don't have a translator? And there was no real explanation. I made a complaint to that hospital.
They really don't know whether or not they're getting good care. They don't know best practices. They assume that they can rely on their doctors to tell them what they need to do. But unfortunately, they're not always getting the best information about self-management and about prevention. For example, here, most people don't realize that you don't have to have an amputation, that you don't have to go blind if you manage your diabetes properly.
The consequence of not having the information for the clients that we see at Neighborhood Shop, primarily Hispanic and African American elders, is death at an earlier age or increased functional incapacity as a result of the impact of the illness over the course of their life.
Another important point is a lot of people feel very disenfranchised with the service providers, and they feel oftentimes that they're not treated well or not respected or not taken seriously.
I think when we first started talking to the community about it, when we first asked people their experiences about the healthcare system, there was a sense of this is not a system that values us. That the people who come in, who are part of the healthcare system as experienced in this community, are not committed to the community residents that they see.
It's very common to go into a teaching hospital in New York and have Medicaid patients still referred to today as teaching patients. You go on the ward and you say, these are the teaching patients. And the teaching patients mean these are people with Medicaid or people who are uninsured. Now, they could be, you know, on the same floor or in the same room as somebody else, but they're called teaching patients because they're poor or they're on Medicaid or they're uninsured. And in New York, you're much more likely to be uninsured or on Medicaid if you're a person of color. So what happens? The teaching cases are the places where students practice and residents practice. The level of supervision they get and the level of personal attention they get is very different than what a private patient would get. They don't have a doctor's business card to take home with them that says this is your private cardiologist. They're sent to the cardiology clinic for follow-up, or they might be seen by another resident who doesn't know them, even though they might have spent 2 weeks in the hospital with a heart attack. When they get follow-up care in the clinic, they're going to be seen by somebody who's never seen them before, most likely.
They got whatever doctor they could get, and sometimes the doctor was overloaded with so many patients waiting for the same care because they don't have a personal doctor, a primary doctor that they can go to. Sometimes for the least little thing that they need, they'll have to sit in the emergency room 6, 7, 8 hours for a doctor to tell you, oh, you could do this here. Go to the pharmacy and get yourself some cough medicine or something.
I have seen and have documented and have case studies of the inappropriate treatment of African American and Latinos. For the Latino community in particular, because the language barrier is so real. And there is a generalization, and the biases and the stereotypes are so generalized. Even the word Latino just, you know, packages us all up into one particular, you know, format. There's such a variety of us, the Dominicans, the Puerto Ricans, the Salvadorians, the Mexicans, who come with all their own health beliefs, knowledge, you know, expectations, or lack of them.
If you create a system of care like that, that's not as good as the other system, the private care system, where people know you, they follow you continuously, and they develop a caring relationship with you, it's no surprise that you're going to get different outcomes for these populations. So we know that the care systems are different. We know that people are seen as outpatients in different settings. Some are seen in clinics, some are seen in private practices. We know that they're seen by different people. Some are seen by students and residents, some are seen by full-fledged attendings. We know that they get different treatment. So then when we look at the disparities on the other end, there's no surprise that we're going to end up with different outcomes, because any of us that have the choice would choose the better private model of care.
Doctor came out. She told him what happened. I told him. He asked me who my doctor was and went back in the door. Left me standing there. Nobody said anything. You know? It was just, you know.
When we talk about racial and ethnic disparities in healthcare, we're talking about the fact that people of color in this country, blacks and Latinos primarily, have much worse outcomes when it comes to almost every disease that's measured in this country. Whether we're talking about HIV, cancer, diabetes, heart disease, or infant mortality, people of color suffer worse.
You know, we did some focus groups when we first started this project. And if you could hear the stories of the people who sat in those groups, when you ask them certain questions about how do they feel, you know, when they go to a doctor, what kind of treatment do they get? What would they like to see different? What's going on? Most people originally, some of them, many of them, didn't even understand that they were not getting the kind of treatment that they're supposed to get.
I was going to a doctor for some years. Never, ever had he given me an EKG. Never had I had an echocardiogram. And just after speaking with Jane Thornton, who was given that workshop a couple of weeks ago, and Dr. Flores, they told me what was available to me. I have the very best of health care, yet my doctor had never, ever given me a simple thing as an EKG. And I'm saying, well, why? If this is something that's covered with my insurance, even if it's not covered, you never told me that I would, you know, need to have my heart checked in terms of an EKG or echocardiogram, and I have high blood pressure. Wouldn't you want to know in terms of what's going on in my body?
During the years, I learned some good things, and I also learned bad things, like they would give me wrong information at my doctor's office. about the levels of sugar and they were right for me to have. And over time, those cause damage. I have neuropathy and retinopathy. I nearly went blind, and now I suffer with debilitating pains in my feet from the nerve damage that occurred.
Pastor Foley, who is our clergy leader for our faith-based initiative, remarked that until he became involved with Bronx Health REACH, he did not know that people who were not people of color were not suffering the same poor outcomes from diabetes as his congregation members were, as people that he knew. They were not losing limbs, and they were not losing their eyesight, and they were not dying because of a poor outcome from diabetes.
I think it begins with education. People have to be educated. If people understand that they don't have to accept being treated as a second-class citizen because of the fact that they don't have as much money as someone else, then they won't accept it. People have to be armed, they have to be educated.
We have huge immigrant communities that come into our facilities that continue to have the same kinds of health beliefs. He's a doctor, she's a doctor, they must know. I'm on Medicaid. I can't ask for too much, because if I start, rocking the boat, they won't see me for 6 months. And Medicaid will only pay for 3 months worth of medication, so when am I going to do the other 3 months? Okay, so no, they don't treat me so well, but that's the only place I've got. All right, external locus of control. A true belief in the Latino community. They've got the power, I don't. It's not playing the victim, it's being victimized.
A black person and a white person have a right to live the same number of years. Somebody shouldn't have to, because of their color in our society, be destined to die 8 years sooner because we're unable to provide them the kind of health care or the kind of health information or the kind of system to support their health that other people get. And that's exactly what we're dealing with. And you can't get a more basic right, I think, in our society than a right to live. And that's what we're talking about when we're talking about health disparities.
Bronx Health REACH is a project that was funded by the CDC in 1999 to look at the problems of racial and ethnic disparities in health outcome. We're located in the Southwest Bronx, and we cover a 4-zip code target area that includes about 275,000 people. And we run a number of community-based health education and public health initiatives to educate people about health disparities.
Who best knows how to identify the problem and fix it than the community in which the problem exists? So we have subcontracted with a number of community-based organizations that are part of our coalition that have joined forces to really making a significant dent and having a real impact, and I underscore real impact, in the disparities that exist here in the Southwest Bronx.
Bronx Health REACH is a movement, and I think that people like that idea of it being described as a movement. I think Dr. Kalman said it best, and he said that he remembers the civil rights movement and how people came together around an issue that was so important to them. And he sees this, and I think the rest of us has grabbed onto this, as something that's coming out of a pulpit, but pulpits all around this area.
Bronx Health REACH is an attempt to bring together politicians and clergy and doctors and nurses and people in the community and patients and everybody to try to understand some of the issues that keep low-income communities, keep people of color, keep people who are uninsured, unhealthy, and to try to address them in a very systematic way and with a lot of community support.
We will know when Bronx Health REACH is successful when we see increased services to communities of color where they have more access to these services.
One of the wonderful things is the community that we have been working in have given us the permission, the opportunity to say, we're behind you, we're a movement, we understand that this is not only us, but we are going to have it fixed here, and then you can take what we've done here and hopefully use it to spearhead changes across the nation. But people must understand that this is not only a Bronx issue, this is a national issue.
We really wanted to do something about disparities in this country, whether it's with respect to health, sanitation services, police services, or any other kind of services. We could get it done if we wanted to. The will, up to this point, simply has not been there to do anything about it. These kids got to understand that a lot of what, in my community, have to understand that a lot of what's going on out there is by design, and it is not incidental in any sense of the word. It is by design.
We need physicians to be able to understand that all white physicians, all Hispanic physicians, and all black physicians all grow up with racial prejudices and values that we need to examine as part of our medical education process, so that when we go out and make decisions about people, we can listen and hear people, no matter what their color or no matter what their education is, hear them all with the same ears and do the same things for them, and be aware of how those values impact on what we do. There's so much that can be done by just building an awareness and a caring on the part of physicians of the incredible impact that health disparities has on so many people in our population. And I think that physicians can play a major leadership role in making that change.
Because a person today is economically situated to provide more adequately for himself or herself does not mean that that is the way it always will be. And not only that, but here's something else to think about. It won't happen in my lifetime, it won't happen in your lifetime, but there has already begun the browning of America. You understand? Where folks who look like me and who are other shades and who speak other languages are becoming more numerous. So what are we're going to teach them to behave this way? I mean, is that what the present establishment wants to do, to teach these people how to behave as they have behaved, so that one day when they become the minority, they find themselves being treated the same way that they have treated others? I don't think they want that. It is in the interest of justice and fairness and righteousness that we take this stand. And anyone who has any common sense, in my opinion, would see the merit of this and also see the danger of standing idly by while these injustices and this disparate delivery of health care is implemented by the doctors and the various institutions that provide it.
We certainly are not where we were, but we're not where we ought to be, and therefore anybody who understands that disparity is still part of our life, that disparity, irrespective of income or financial circumstances, that when you step through that door, you will be stripped many times of sort of who you are, and you'll be seen as a person of color, and will be treated as a person of color. And if we are to move beyond that, then we need tangible commitment from those who have benefited, from those who are reaping the benefits of those who contributed before us, so that we can then turn around and make sure that those who come after us will benefit from what we have put in. And that's really how we're going to get to where we ought to be.